A hypermature Morgagnian cataract with fibrosis in the capsule and subcapsular areas. A translimbal keratome entry is made, creating a tiny conjunctival flap. The entry is actually in the anterior most part of the sclera. Visco in the anterior chamber, HPMC. Tunnel floor entry with the cystotome. A sweeping crescent-shaped capsulotomy is done. In the area of capsular or subcapsular scarring, the tear does not go beyond certain point. Nucleus epinucleus is rotated with the cystotome. Tunnel enlarged. The fibrotic band in the capsule and subcapsular area did not look very significant, but yet prevented the capsule from tearing, and this was abandoned for the fear of zonal loss apparition. There was a pull on the equatorial capsule during the process. I am aspirating the loose cortex from the capsular bag, inflated the anterior chamber. A small nick is made with Vanna scissors, and rhexis is performed in the other direction so as not to go across the fibrotic area. Deflating the capsular bag with earlier rotation of the nucleus and aspiration of the cortex, especially from the central as well as peripheral area, has eased this method. This capsular flap does not come in spite of a tear in the capsule because of subcapsular fibrotic elements. You can still see them. Tag is still there. It's cut with Vannas. Now it comes out. There was a pull on the capsular bag in the lower nasal quadrant. Nucleus can be easily prolapsed into the chamber, bisected and removed from the anterior chamber. Rhexis is intact. As it's a hard nucleus, bisection with the shaft of a 25 gauge cannula is inadequate, does not complete. So a cystotome with the sharp tip is taken inside to bisect the nucleus, and then each piece is removed from the anterior chamber by continuous infusion of visco, which protects the endothelium. The other half is brought in line with the tunnel, similarly supported by a wire vectis, a mini wire vectis, and then taken out through the tunnel. Everything is fine till now, but soon I see a tear in the posterior capsule extending from, as you see on the video, from 11 o'clock to 4 o'clock. You start seeing it now. Still not there. Now we can start seeing it's a D-shaped tear. Hyaloidal phase is intact. As you can see, there are no fibrils. The posterior capsule can be easily reposited by injection of viscoelastic. The main thing that we should do at this point of time is to remove every bit of cortex, which is the cause for postoperative inflammation in such cases. Note that the hyaloidal phase is still intact. The aspiration of cortex is possible. Vitreous fibrils are not going into the tip of the aspiration port. This is a very low pressure technique where the infusion and aspiration are finely controlled, and you see that the cortical particles are completely aspirated without disturbing the hyaloidal phase. Neither the particles of cortex nor the viscoelastic has entered the vitreous chamber. Hydrophilic lens was planned in this case. The same lens was taken, and as the rhexis is intact, as there is no vitreous, we plan to put it in the sulcus. Carefully, iris is pushed a little bit to expose the anterior capsule with the tip of the leading haptic, and then ensured that it remains in the sulcus. Trailing haptic is also dialed so that it goes and lands, parks itself in the sulcus. As you can see now, you can see, visualize it and then put it. Then entire visco is aspirated. We are not going in behind the lens as the vitreous phase can get disturbed. Cortical particles and all visco from the anterior chamber is removed. That's the end of surgery. Post-operative period was uneventful. The extra pull on the anterior capsule to circumvent the capsular and subcapsular fibrosis would have certainly pulled the zonules and would have tractioned the posterior capsule, but whether it is the reason for the posterior capsular tear is not uncertain. But this patient has done exceptionally well during the post-operative period, and you see a fluid wave traveling in the hyaloidal fossa from the upper wave as I'm forming the chamber. Let us see the anterior capsular management in slow motion. Rhexis could be completed comfortably, and it stops at the place where the subcapsular or capsular fibrosis is present. A pull on the rhexis with the hope that it will tear is not yielding results. The pull is little more than what is ideal on a retrospective thinking. You can see how much is a pull, and that pull certainly is exiting onto the posterior capsule. And then what I did was the right thing, took a reverse rhexis, but even in that could not complete the rhexis in the fibrotic area. Rest of the area it came out easily. Capsule is separated, but the subcapsular fibrotic band is still holding on it, as you can see there, and that could be only released by Vanna scissors. However, after the nuclear extraction, the capsular tear was not visible in the early part. Only in the later part it started visibility. Whether it was hidden or it became prone to the capsular tear, or capsular tear is entirely a de novo occurrence, is still uncertain. A low aspiration, low infusion, low pressure technique, which does not increase the pressure in the anterior chamber, makes this complex surgeries easier and possible. Thank you.